please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
We are here. It's Wednesday.
It is. I love Wednesday. It's my favorite day.
Who would have thought we would have turned such a funny, no one really likes Wednesday, it's the middle of the week, into so many people's favorite day of the week.
Hump day. Yeah, it's like, no, it's my favorite day of the week.
Yes. How has your week been so far?
Oh, well, I get to see patients Monday, Tuesday. Magic and things that I did not expect.
Okay.
Patient that had during COVID, she had COVID, went to the hospital with just a respiratory infection, and 24 hours later, half of her brain was gone. She had a stroke, like massive, the most, not a simple sensory motor cortex stroke like people get. This was half her brain.
Wow.
And Sandra has been treating her, and every time she treats her, she has some improvement. And then 18 months ago, things start to change, and she developed pain. So she has spasticity on the left side of her body. And she started having pain on the right side of her body, on her leg in particular, and other things. So her right arm was tight. She could use it. She still had motor, but the tone in the upper right just wasn't right.
Mm-hmm.
And so we put a wrap around her neck and a wrap around each ankle. And I ran the frequency to increase secretions in the sensory and motor cortex to get the spasticity better on the left. But if you touched her right leg, she would scream. And right-sided brain
Was it pain or sensitivity? What was the
pain? Like really, really, she could say, "Don't touch that. It hurts."
Okay.
Right-sided brain strokes change the personality. And for example, they have left side neglect. They can look at their left arm and don't know who it belongs to.
Right.
So from her neck to her right leg, I ran the frequency for thalamic pain.
Mm-hmm.
It's the only thing that made sense. I used the converter in case it was nerve pain, but that didn't make any sense because it started 18 months before. And it's not like she's moving. She's in a wheelchair. So in 60 minutes, her right leg didn't hurt anymore. And she was still all slumped over. Well, the next day she comes in with her adorable husband, and she's sitting upright, like with her head up, not slumped over like this, the way she's come into the office for the last year. And I ran the frequencies for the virus, the R6 flu frequencies, in the capillaries, the cortex, and the sensory motor cortex and the thalamus. Just kind of did a drive-by. And she had a facial expression instead of the mask that right-sided strokes make.
Mm-hmm.
And with her right hand, she is exploring her left arm. Like instead of it not even being there,
Right.
she's touching it. And her shoulder like, I wonder this is interesting. She held her. I mean, who knew? And it's not like hard manual labor. It's not like working on somebody's shoulder.
Right.
I'm sitting there with a wrap around her neck and a wrap around her feet and 3 machines connected to her. So I ran concussion in Vegas because what appears to be happening is that there are more clots and the stroke is spreading from the right side to the left side, heading through one part of the thalamus on its way. And that means that we need to increase blood supply to the brain. And people that do FSM know that increasing secretions in the vagus increases nitric oxide and increases blood supply to the brain. So I ran concussion in Vegas on a 3rd machine. And then when we were still treating her, I threw in vagal tone. And who does that? Who gets to do that?
We do.
We do. It's like, how, how do you explain? I had a conversation with a documentary filmmaker this morning, and she said, well, we're going to do this and this with people who are singing and using voice and tone to treat sick patients. What does it look like when you're treating people? Well, they have a towel around their neck, and in this case, one around her ankle, and I'm sitting there talking to her husband about engineering.
So, but there's so many beautiful and profound moments happen in that silence that, yeah, it may seem super boring to a filmmaker or to somebody who is just scrolling through Instagram, and yeah, somebody lying on a table with a wet towel around their neck. So what? But to the person that was in pain 5 minutes ago and whose face was all scrunched up because they were in pain, and for the woman who's holding her shoulders because she was in pain, to see them on the table in extension with this not just neutral expression, but blissful expression on their face, or to see like this super shy teenager that never talks opening up and telling me all about their day and their teacher and their grades and their girlfriend and their and the mom going, keep him talking. Can you just keep him talking a little bit longer? I'm getting so much out of this kid. He never talks. So when we see those side things, it may not be a big deal to so many people. And that can be the turnaround point for healing.
Yeah. Yeah, I don't even know. I'm supposed to do an introductory, what is FSM webinar, podcast, something on the 29th. And I'm making the slides. And so I'm using the published papers, but how do you describe in 60 minutes, even in a few minutes out of the 60 minutes, I have to figure out a way to describe what it's like to do reproducible magic.
Right.
Patient with five lumbar discs, L1 through 5 lumbar facets, left hip replacement, L1 is numb, the lateral femoral cutaneous nerve is numb, and her left glute is completely shut off, hasn't contracted since the hip replacement. That's like, oh, that's easy. They did an anterior approach. Your femoral plexus is glued down, and so your glute doesn't fire. For us, that is normal. That's like, well, of course, yeah, that part's easy. I don't worry about that. And your low back, that's facets and discs. And the only thing that would cause all those facets and all those discs would be your psoas on both sides. I'm thinking this in my head because it's not going to make sense to the patient because she doesn't know what the psoas is. So I work on her psoas on the left, work on the L1 nerve root, work on all the nerves that are irritated. On the auto care, run subacute facet. On a custom care, run disc repair on her low back. Then manually just do inflammation in the nerve, scarring in the nerve and the blood vessel all the way down the femoral plexus. And long story short, she gets up, her pain's a 3 instead of an 8. She's also a cervical trauma fibro patient. But she said, oh, I don't pay attention to the body pain. I said, well, do me a favor, on your pain diagram, fill in it. I'll give you a pencil. You don't have to cop to it. You can put it in pencilable. And so she draws the cervical trauma fibro. I said, don't forget the circles on your shoulders and your elbows. Elbows aren't too bad. How about your hands? Oh yeah, my hands and your feet and your knees. Oh yeah. So she draws that pain diagram. So I ran 40 and 10. I had 9 machines on her.
Wow.
40 and 10.
Is that a record?
Pretty much. I beat Ben Catholi, which I think is quite an accomplishment. I'm very proud. And so the body pain goes away. But as I'm working on her leg, I get to the hamstring and it's tone.
Yeah.
Wait a minute. Wait. What? She's had 3 rear end accidents. Feel her other leg, hamstring tone on the other leg. So I just grabbed another precision care and ran 81 and 10 at the same time.
Mhm.
So she gets up and the hamstrings don't hurt and her knees don't hurt and her feet don't hurt. And the nerves that were numb and icky are now normal. Her back pain's gone. Her neck pain's gone. Her flexion went from 52 to 70. Rotation went from 60 to 85. And she has now her right, I didn't work on her right psoas. So I'm going to do that tomorrow. How do you tell people what that's like? Yeah, it's
Well, if you don't know,
everybody that's who's with us today. There's 30 of us here.
Yeah.
So the 30 of us know, and the 150 people that are going to listen to this on YouTube, we know.
Yeah.
And then you try and explain it to somebody else. It's like, well, that's the other reason people come to the advanced. It's the only place you can go and sit next to somebody at lunch and say, well, it was really just not that hard. It was just 40 and 89 and 40 and 10 and a little bit of facets in the psoas. And it's like, it wasn't that hard.
Because you've made becoming the detective and figuring out the cause, that has become the norm. That hasn't become the outlier or the exception. And in our allopathic medical model, that's just, functional medicine is different. But when you go to your physician and say, I have hip pain, they're not trying to figure out why you have hip pain.
No.
And that's the first thing we start thinking about. Why? And if you're a neuro geek, we're going to the neuro side. If you're a pelvic geek, we're going to the alignment of the pelvis. If you're a podiatrist, we're checking the feet. If, there's so many different practitioners, but we all have that one thing in common, is asking why.
And with her, she's 5'10", healthy, no childhood abuse history, not centralized, keeps exercising, has a clean diet, all that stuff. But she has wicked arthritis in her neck. She's had her left hip replaced at the age of 62. She has facet degeneration in her low back. She has a degree of inflammation that doesn't make any sense. And I said, what happened to you? And she had asthma and respiratory stuff from about the age of 4 or 5. And I said, what happened to you when you were 3? She said, I don't know. There's 6 kids and I'm the second one. And so I don't know what happened, but it's funny you should ask that. I saw an acupuncturist once who was very sensitive, and she looked at me and said, something happened when you were 3.
Wow.
And she said, why did you ask me that? I said, well, the only way that somebody has this much pain and this much inflammation in the joints, because what creates inflammatory joints is inflammatory healing. You'll have people that, she has the kind of low back and neck that somebody has after they've done saddle bronc riding for 6 years in their 30s, right? And she's never done any of that. So what created all the inflammation? Why? The vagus is in charge of turning down inflammation. And the only way you have that many allergies and asthma is if your vagus wasn't working by the time you were 4 or 5 when you started getting asthma. So something happened when you were 3-ish to turn down the vagus. And she went, I don't know, but it's funny you should mention, because this other lady did. So our job is to turn her vagus back on. I'll treat her asthma tomorrow and her respiratory system tomorrow. And get this, that's the why. Get this system turned around. Her diet is anti-inflammatory. She had a difficult first marriage, a magical second marriage, 3 healthy kids, all on to new and good lives. So she's just like, she already has a stable state, but something unhinged it early. We can reverse that by turning the vagus on, but it's easier to turn the vagus on when you know what turned it down.
Right. And you've just described how I describe to clients the short-term play and the long-term play, right? So the short-term, the athletes and the active people kind of get that, like
Right.
what's going to happen in the next few hours versus what's my plan? You're not going to tell me to stop running. You're not going to tell me to stop skating, blah, blah, blah. So
Yeah.
short term, you're like, this is easy. We get the Vegas turned on. And then you would think all these other little switches start. It's like a domino effect once that Vegas is back online again. But as you always say, it's like bailing out the boat and shooting holes. Like to really close the case. I mean, yes, doing all those things is going to make a huge difference. And yes, it's so much easier when somebody has that stable state in place. But then there's that one missing piece of the puzzle.
Yeah. And I have to credit Harry Van Gelder for that. And
Mm.
George. George would tell the story about about the patient that Harry was treating. And Harry's muttering to, so George watched Harry for 3 months. And Harry's muttering to himself, this doesn't make sense. Ah, he rode his tricycle down the stairs when he was 3. He has a chronic concussion. So he would treat the concussion protocol. And that's why we run the concussion protocol on everybody, just because you never know when it was that they dropped off the monkey bars when they were 5 and don't
Right.
remember.
Right. Yeah. And sometimes it is something not as little as falling off the monkey bars. Like those are pretty big memories, but every person has their own way of filing these memories as to what was traumatic and what wasn't. And that big T, little t that we always talk about. So that big trauma to somebody is somebody else's, like, of course I fell down the stairs. I was knocked unconscious. I think I was down there half a day before my mom found me. Like it's just
No big deal.
no big deal to certain people, right? So I think asking the right questions definitely helps. Doing that thorough patient history, like you said, your first visit is hardly any therapy, right? It's just kind of going through that.
First was she came in with a very nice linear history,
Yeah.
1 MRI, these 3 accidents, and oh yeah, there was this surgery, and oh yeah, there was that, and there was that, and there was that. So it's the history is not realistic for almost everybody that's listening. There's not that many people. It's really nice being my age because I don't really care. It's like I'm going to do it my way. Finally, I get to I earned the right. So I get to do a 2-hour history and an hour and a half treatment. And she wrote me a check without a twinge because her pain was gone. And she knew insurance wasn't going to cover it. But in a realistic world, you can take a shorter history the first time because you're going to see them 2 or 3 times a week for 2 weeks and then twice a week for 2 weeks after that. So we have time to put pieces of the history together a little bit at a time. Talking about the way I get to do things doesn't fit everybody that's listening. And there are, in some ways, it's easier when you get to see them twice a week for 4 to 6 weeks, because you can treat things as the patient recovers and fix the compensations as they show up.
Right.
And it's really easier. I have to do it all in 4 days.
Right. When you have people coming in from out of town, you're under the gun to make these improvements and have these improvements hold.
Fast. Yeah.
It's funny, in the last little while, I've had a big group of the client base kind of transition to maintenance. And I have one person that was like, I'm not ready to go down to once every 2 weeks or once every 3 weeks. I'm like, I think you are. Like you're doing great. There's been no sides, like I think we're ready. No, I don't want to risk it. I'm like, okay, how about we just go down to half an hour treatments instead of a full hour until you're comfortable enough. So it's the confidence too that we're giving people that, and it's a bit of that disbelief. We talk about the disbelief that happens really quickly in the clinic, that happens when you have somebody who's like a 6 or a 7 out of 10 down to a 2 within a couple minutes. And they're just like, and you ask them to move and they're not really computing how the pain is gone because they've had the pain for so long. But the same thing happens when you're person is out of pain for a while, they're almost expecting it to start. They think if they don't come to the magic room with the magic towels, something is going to happen. And I just want to keep safe. And so it's that safety and that confidence that to transition somebody, so the practitioners that are listening, when you go from that twice a week or once a week and now think, okay, let's try to go once a month or once every 2 weeks, that can be frightening for some people, because when they've been in pain for so long and then they're out of pain, they don't want to go back to chronic pain ever again.
And they're used to passive palliative care. Almost every other methodology, whether it's drugs, even physical therapy, ultrasound, heat, whatever, is designed for temporary relief, because nobody else aims, not nobody else, but in particular, we aim to fix the cause. If the cartilage is torn and broken and inflamed and degenerated, those are the frequencies we use for the poor cartilage that's all beat up, and then vitality in the cartilage. So our purpose is to fix the cartilage.
Right.
Who else can fix the cartilage?
Right.
So there is the medical model, as you describe it, is passive care, here,
Yeah.
have a massage,
Yeah.
and palliative. It's
Right.
pain relief and it'll last a couple of days and then I'll see you on Friday. Forever. And for us, it's gone.
Yeah.
And when you come back in on Thursday, it's still gone.
Right.
And then it's still gone. Yeah.
Right.
There you go.
Yeah.
And then you see them the next week. Those of you that have a regular practice, you see them the next week, and part of it's still gone, but then something else shows up someplace else. Well, that makes sense, because now your left hip is acting this way, and now your right hip is wondering, what do I do now?
Right.
So we'll fix your right hip, and the two of them, it'll be okay.
Right.
And so at the end of 4 weeks, it's like fixed.
Yeah.
And the stable state is go for a walk. What do
Yeah.
you mean, go for a walk? It hurts when I walk.
No.
Does it hurt when you walk now? No, but it doesn't hurt when I walk now. Okay.
Yeah.
So tonight, go for a walk for 5 minutes out and 5 minutes back.
Yeah.
10 minutes. It's going to be fine.
Yeah.
And then,
Yeah.
so
It's
you have to build that confidence that it's going to last, and getting them to understand that FSM operates differently.
Yes. Yeah, there's this 8-to-1 ratio that we talk about a lot. So for every one bad experience we have, we need 8 good experiences to cancel that one out.
I didn't know that. That's really cool.
Yeah, so it'll happen with like bad. So you went to a restaurant and you had a terrible, terrible meal. It was bland, it was tasteless, the service was horrible, you had a stomachache after. Chances are you're going to tell about 7 to 8 people about that. But if you had a great experience, you might only tell 1 or 2. That's just the way we operate. So similarly with injuries, once we get, let's just say, a dislocated shoulder neutralized in a hockey player, so there's no instability, imaging shows it's strong, they're going to need 8 times the amount of repetitions that are pain-free for their subconscious to think, I'm strong enough to withstand the brunt of it. So
do you think that 40 and 89 can reduce that number?
yes, I am absolutely seeing that clinically. So the emotional, we talk about this all the time, like the emotional attachment, the wonderful slide that always stuck out to me from the very first core that I took, and mind you, I was a new mom during that time, was when we're talking about the first few frequencies of the concussion protocol, and there is a sentence in the slide that says, if you've ever tried to apply a Band-Aid to a screaming 3-year-old, you understand this concept. So that screaming 3-year-old that has the scraped knee is like the screaming midbrain that's like, this movement dislocated my shoulder, even though that happened 6 months ago, it's going to happen again. So we know that 40 and 89 is that safe to move feeling, and it has that effect. So I'm absolutely seeing that clinically. We're seeing athletes coming back, and even not even just athletes, but in quotation marks, but just our active people who are afraid to go up the stairs because going up the stairs once hurt their knee, or going down the stairs hurt their knee, and now they don't want to do the stairs anymore.
Yeah. And yeah, it's.
So what is that ratio with 40 and 89? I don't know. Maybe it goes down to half. Maybe it's 1 to 4 instead of 1 to 8.
One can hope. I do know, and it's one of the reasons that remember that picture from Cloward of the referred pain from the disc annulus?
Yeah.
I used to have the picture in there one time, and people they weren't getting it. And then I remembered that somebody has to see something 7 times before they remember it. So now in the core, there is a picture. That Cloward diagram is 7 times in 5 days.
Right.
If I did everything 7 times, then we'd be there for 2 weeks. But that one, I want people to remember. And this year at the Advanced, John Ruskey is back for the 4th or 5th year. And somebody said, why is he coming back? And I said, well, we are going to be the people that pick up vestibular injuries. I'd finally made a patient information handout slide, a handout on vestibular injuries, explaining what they are, what they cause, what can be done about them, and it took 3 pages.
Yes.
And actually in 2 days, I handed it out 3 times.
Wow.
Because so many chronic neck pain patients have chronic neck pain because their neck muscles are so tight because their inner ear is busted.
Right.
And so tight. Yeah. And
you have that for all of us to see somewhere?
Did I give it to you so you can put it on the resource page, or didn't I send it to you?
Which one?
The information for patients on vestibular injuries.
Well, we have the BVIS.
Yeah, we have the BIVSS, but this handout,
But I'm
Kevin,
that's what I'm
yeah,
I'm working to put the page together. That's what I started.
okay. Kevin's putting the page together, and I will send him, it's a Word document, so I will send him that, and y'all just feel free to print it off. And because I'm sitting there explaining to a patient how the vestibular injury affects her life, and her eyes got a little blank, and it occurred to me, it's like, oh yeah, vestibular injuries interfere with the transport of information from short-term to intermediate term to long-term memory. So I sat there and told the patient, you're not going to remember any of this tomorrow. So I had the handout ready the next day.
Smart.
Yeah.
Speaking about vestibular injuries, we would talk about 94 and 94 would make people feel typically yucky who have vestibular injuries.
20% of vestibular injury patients, because I have a lot of practitioners that have never seen a problem with 94 and 94.
Right.
20%.
Right. And because I was going to say, I have a lot of people that have had confirmed vestibular injuries that have no problem with it at all. In fact, so if that's 20%, I would like to find a new percentage of people who have vestibular injuries that absolutely love 94 and 94. I'm designing my new hats right now for the Advanced, and part of me wants to just put a little 94, 94 on the back of the hat, and just the FSM people would know, because it is my absolute favorite frequency combination on the planet that I've ever tried. I'm like a drug sniffing dog in a ballroom of like 100 people. If somebody is running 94 and 94, I just want to go sit beside them.
Yeah.
Can I just be here?
I'm like that with 81 and 109. It's like, I'll just sit here. Just turn my babies on. That's
right. Yeah, because that feels good too. But nothing like 94 and 94. And I have not got immune to it. I had somebody the other day that was like, I really miss like how stoned I was when I first came in to see you. She's like, can you turn it up or change it or something? I'm like, well, we'll try to replicate it. But yeah,
It's-
94 does it to me all the time.
Well, and when you think about what our practitioners go through, everybody that's listening, when you hear patient histories, I don't know about you, but if you're at all empathetic and you hear a history that includes, they did what?
Right.
What? And that? And then he,
Right.
right? That's a
Right.
concussion for you.
Right.
Sometimes it's a concussion for the patient to talk about it because it brings all that history up.
Right.
And so, and then you drive home, and then there's the guy that thinks the red light is like, or yellow, it's orange. And then there's,
Yeah.
so I run the concussion in Vegas on myself every single night.
Right.
That's
I have to be better at that because yeah, we're not robots. And I think FSM practitioners are some of the best practitioners. The people that find FSM from their practices, they're special people, right? Because there is that burning flame inside of them that says there has to be more than this. I have to be able to do more than what I'm doing. There has to be more to the story than whatever. So just that desire and that courage to be an FSM practitioner sets you apart from the rest anyways.
in general, my favorite FSM students are people, physicians of any stripe, clinicians of any stripe, that have been in practice about 10 years.
Hmm.
They're good at what they do,
Yeah.
and they know what they can't do.
Right.
And they're looking for another tool for the toolbox.
Yeah.
I don't want to stop what I'm doing, and then they find out what FSM can do to add to what they're already doing manually, or with needles, or with herbs, or with medication, or with supplements, or colonics, or whatever.
Right.
And yeah. And Anonymous says the people that adversely react to 94 and 94, probably it can be reversed with 40 and 44. So
Right.
at the activity of the inner ear, or 40 and 94,
Right.
or both, or
Right.
lacking that, just a dose of meclizine and wait 20 minutes. It goes away. The reason I talk about the 20% are the number of practitioners. So you go on Facebook and somebody says, I treated somebody Monday and they had a headache Tuesday and they were nauseous, and now they're on, and what happened? And it's like, what did you run on Monday? I just ran the concussion protocol and treated their neck. Did you do a vestibular screen when you did their physical exam?
Right.
Oh, well, try 40 and 44 and 40 and 94, or give them a meclizine.
Right.
It's the ones that miss it because it'll scare the heck out of the patient. I don't want to come do that again because it made me really sick and gave me a headache and made me throw up or made me dizzy and nauseous.
Right.
And then it scares the practitioner.
Yeah.
'Cause when they react,
Yeah, it's scary, especially when you're so used to like just doing good things.
yeah.
I do have to say, I used to say, you know, for all the athletes that I worked with, I would always stay in the room during concussion until at least 94 and 94 passed. And if they didn't have a reaction initially, they typically didn't. However, there was an outlier last year for me who loved the concussion protocol. I was in the room anyways, and all of a sudden he started sweating. He got very pale. He's like, I
Uh-oh.
feel like crap. I looked, sure enough, it was 94 and 94 time. I just paused the machine. All I did. And he's like, okay, that was terrible. I'm like, so I just took the towels off, let it run until 94 was done, and put it back on, and he was fine. So I didn't have a need to reverse it with 40.
Oh, good.
Because it really just hit him fast and hard. And I think Keith Pine talks about when that happens too in the locker room, he lets guys just throw up as long as it's not on his shoes, he's fine. And then he goes on his merry way. That doesn't work in my clinic. I don't want to have people throw up on me. But like I said, I am admit when I'm proven wrong. And so sometimes, and maybe this person did have a new vestibular injury that I had missed since the last time I had seen him because it had been a year. So to your point, do the screening all the time, especially if you haven't seen somebody in a while.
Yeah, it's just, and yes, all of my patients are new patients. I'll have 2 new patients on Monday and then repeats and a second new patient on Thursday, something like that, or Tuesday, something like that.
Right.
And it's doing a vestibular screen and screening for Ehlers-Danlos or hypermobility has become standard
Right.
because we get such outliers. It's not like we get the world's easiest patients most of the time.
No.
No. And sometimes God
And
is,
then we're shocked. And then we're like that other person that we're like, and I think you and I will text each other like, was it really that easy? Because we're so used to something complicated that everybody else has missed, and you're hyper vigilant, but sometimes you do get the treats.
yeah, every now and then you something easy or normal is what you ask for. It's like, okay, I really need a rest this week.
Yes.
And easy people get off the bus and you treat them for a week or two, and then the universe says, okay,
Did
it's
you
time
have
to go
fun
back to
during
work now.
vacation? Yeah. Yeah. Hope you had fun. We had a lot of email questions that came in the last little while, and one came in
Oh, yeah.
today that I'm not sure you had a chance yet to see or respond to, but I kind of going along the track. It said, is there any tissue that it would be unsafe to run 124 or any condition? It said, she wrote tissue, but I'm just going to say in any. 124 is typically not one that I've ever feared for an adverse reaction because I feel like everything in our body could use a little repair and heal, or has been torn and broken.
Mhm.
I don't know. I haven't.
David Musnick running 124 and 22, torn and broken in the small intestine to repair leaky gut.
Yeah.
And he runs it for 60 minutes.
Yeah.
And you run it for 5 days in a row.
Right.
That was like watching the sun come up in the west for me. It's like, what? It works? Seriously?
But
Oh,
it makes so much sense.
it made perfect sense.
Right.
And then you can think of, well, the liver and then the periosteum. Yeah, that could work. And then, so while I'm treating this stroke patient, I don't know, I tell her husband, I can't put tissue back that's not there. And then she comes in the room the next day sitting up and using her right arm. I can't put tissue back that's not there, but she's sitting up and using her right arm. So, okay. And one of the things I ran was torn and broken in the cortex, the sensory cortex. And you look at the MRI and all of the tissues, the basal ganglia, the insula, just, yeah. So I did torn and broken in all of them. I did inflammation because it's the halo of inflammation around an ischemic area. So her strokes were caused by blood clots.
Right.
She's having more blood clots from something. So her husband's job when they go back to San Jose is to take her to their GP. I don't like medical doctors. I said, you don't have to like him, but he's the only guy that can do what you need.
Yeah.
I want her to have an EKG and I want a new MRI of her brain.
Mm.
And you might want to try this drug. We don't like drugs. Well, this one doesn't have much in the way of side effects and it's going to help her arm.
Mm-hmm.
Okay, fine. So it's the why. And 124, she's sitting up. I can't put tissue back that's not there, but I apparently just did.
124 has been like on our spotlight for the past few years, ever since we figured out it was time dependent.
Oh,
hey,
Diana Cross. Sorry, Diana Cross.
I saw her on the schedule. I
know. And Diana Cross is like, I would say a dog with a bone or a terrier kind of. She just keeps digging.
Yes.
And she emailed me 3 weeks ago after I thought I had the symposium schedule all set.
Yeah.
And she said, I'm coming. I've been doing more work on 124. And it's like, okay. So I had to email everybody that thought they had 90 minutes and say, guess what? You get 60. And we found a place. And this turns from 60 into a 30-minute case report. And there's Diana Cross. So she's going to tell us more about 124.
I can't wait because, to your point, 124, super safe on so many different tissues and conditions, everything, whether you subscribe to the torn and broken or repair and heal, It both works the same. But then you start thinking, okay, but why is it torn? Right? Those of us who are asking, so how did it get torn? How did it get broken? Why does it need repair and healing? Was there trauma? Was there bleeding? Was there a surgery? What led to the surgery? What like blah, 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 blah. And so that it forces you to ask the question. So I have a funny quick story to tell. I have been struggling with some kind of deep hip pain on my left that is not really hip pain, but somebody had said that it's my labrum. And I said, well, that is what it is. I'm going to keep running and I just have to, I'm thinking in my head, I just need to run more 124 and 214 and everything will be fine. So the practitioner is very bright, was saying you need to do more strength training because your glute is weak.
Yeah.
And I said, okay, let's just entertain this thought. I go, if my labrum is torn, do you think my glutes are going to magically appear online and turn on because I have tearing in the labrum or a bone spur? And they kind of gave me a blank stare. And so
Nobody thinks like that, except us.
no, but he's like, well,
Yes.
I guess you kind of have a point. And I said, so doing all these activations before my run, do you think that's going to magically make my hip stronger and pain-free? And I kind of had I swear it was like 10 minutes of just staring at each other. Said, okay, I'm going to blink first. Thanks for the advice. I'm just going to treat myself at home. I'm glad we had this appointment so I could walk it through in my head what I need to do. But I have, and I thought of all the years that I used to do a lot of exercise prescription and just say, oh, something's weak, let's just turn it on, and never thinking why something would be inhibited.
Right. It seems to me that when you were on the table in Hawaii 2 years ago,
Yeah.
it was your left psoas that
Yes.
was tight,
Yes.
and the psoas is attached to the femur. And if the psoas is tight again for some reason, then the femoral head gets jammed up into the acetabulum, and the labrum, the acetabulum have an opinion about that. And have you found is there anybody near you that could go in and mash on your psoas, or do I need to get on a plane?
I wouldn't do that to you. I would come up to see you. I'm going to reach out to some prospective mashers. If not, I'll see you in Arizona.
Okay.
And there's that time. It's not excruciating, it's manageable, but I have another race coming up and I want to get it under control. So
Okay. Well, I've never tried working on my own psoas.
it's not easy.
Awesome.
Trust me, I have tried to get in there and it feels good at the moment, but then I start like palpating like, ooh, what's this? And is this my ovary? And what's that over there? So it turns to more of like an exploratory moment. And I am really against using those hip hooks and those utensils. So, and I call them utensils because that's what it looks like to
Oh
me.
no, it's terrible.
I
No,
should
no.
build tacos on and not lay my abdomen on top of. So until then, there's 124 and it'll just repair and heal all the good things around there. But as a skeptic, I wasn't a skeptic. I was cautiously optimistic about using 214 or frequency for meniscus and labrum. It works very, very well on hip labrum. Yes. So,
and it's a surprise. It was an investigational frequency.
right.
Just stumbled across it. First place I used it was in the knee, and it worked.
Yeah.
Well, that's a meniscus, and you look at the labrum, and it's like, well, it's we can try it.
They're for sure like biologically related. They're for sure first cousins.
And then the magic was in the shoulder, torn and broken in the labrum, and then you get the humeral head, you get the elbow up, you get the humeral head right over it, and then as you're in torn and broken, repair and heal the labrum, the humeral, all the muscles relax, and the humeral head just slides around the edge of it and slides back into the socket. It's like magic. It's just. Oh.
I had an instructor years ago that said, we have to have the belief that the human body knows where it needs to go. We just have to create the space for which it needs to travel.
That's a good instructor.
Yeah, for a manual therapist, that is sort of the dogma and the mantra, as opposed to like really kind of violent chiropractic or osteopathic manipulations where you're just like, I'm just going to force this and deal with the collateral damage later. So, when you're thinking of those, especially those very movable joints, right? The shoulder, the hip, that is not reliant on the labrum for stability. Like, let's face it, like without the rotator cuff, the shoulder would not sit in the labrum, it would slip. right out. But those surrounding muscles are reliant on the labrum for constant feedback. Are you cracked? Do I need to tighten up more to provide stability? And then that loop can just become
That's like, where do we need to put the humeral head so the labrum's going to be safe?
right.
And then, yeah, it's amazing.
It's a whole conversation that we get to just kind of sneak into the room and be like, I'm just going to sit here and listen for a little bit to see what you two are saying to each other.
Listening with my fingers, and it's like, why is that? Gee, that muscle's kind of tighter than it should be. And why is your pec minor pulling your shoulder forward? And why is, what happens if we, and this complete lane change. Same thing with the ability to treat the Dura. So Eduardo Gallo from Italy, he's an osteopath. And we treated a patient in Italy, in Rome, who had dural adhesions. And the change in that patient was extraordinary. That set Eduardo off on a path, and he's doing an hour long at the advanced on the Dura, when and why you treat it and what happens and why you would do that. And that's the other one. When the patient, when their posture is strange,
Yes.
they can't, oh, my hip flexors are always tight. I can't flex my knee. So you lay them on their back and their knee stops at 90 degrees.
Right.
Yeah, my hip flexors are really tight. It's like, no, that's your Dura. It's like, excuse me?
Right. It's because hip flexors are what so many people have told them, because it's easier to treat a hip flexor than it is to treat Dura.
The fact that it doesn't work is another conversation. But the nice thing about us is we get to treat the Dura.
Yeah.
And it not only frees up the hip, but the thoracic spine and the cervical spine.
Right.
And the patient gets up and everything, like, there's
Yes.
the dancing in the kitchen.
It's just that reorganizing is what I see is I just need to reorganize myself, right? When you think about your spine and the attachments and the relationship the Dura has with everything, it's so exciting that Eduardo's going to talk about it for so long. I was like looking through the schedule going, I'm going to be brain dead by the end of this, but I can't miss a moment.
No, and we will have tables in the back, so people want to work on each other.
Yes.
But and being there in person, we have already like 140 or 150 people signed up, but a lot of them are online, and I'm hoping more people plan on actually being there.
Yeah.
Because there's something about sitting at the lunch table,
Yes.
sitting next to Eduardo or you or any of the speakers,
Right.
Jerry Pollack and Diana Cross, and
Yeah, just being able to hear them speak, and not only just hear them speak, but not only just the speakers, but some of my dearest friends that I text now when I am in not just medical trouble, but like trouble, are FSM practitioners that I met at the advanced. Like, this isn't advertising to go, but there is something just about meeting your people. And like I said at the beginning, like the FSM practitioners got into FSM for a reason. And it's not about making money. It's like not one of those meetings that you go to, right?
Yeah.
There's something deeper and more profound about it.
It's our tribe.
Yeah.
We attract a very particular kind of intellect and personality. It shows. There's a kind of joy at the Advanced and Symposium that is just,
there's this collaborative excitement about sharing, right? Especially the symposium years, because we get to hear so many more case studies, and the case studies are great because either two things are happening. Either you're just like, wow, I never thought about using it like that before, or you're like, yes, I have been doing it like that. So, because sometimes you feel a little lost. So that validity and that confidence of, okay, someone else did what I did, and look at me, and look
Yeah.
at look at everybody. I
I
mean,
was right.
I was right. Yeah. So you've got that like-mindedness that, the word tribe is probably the biggest thing that sums it up. And you just don't get that online.
No, I mean, you get the education online, you get the video, you get the audio, but the community, FSM is the email I sent out after a core, welcome to the FSM family.
Yeah.
It's, 7,000 practitioners in 23 countries. And by the way, Hannah,
Yes.
little 18-month-old that was there 6 years ago,
Yes.
she's 8.
Yes.
And she insists on coming to the core with mom.
I love it.
So
I love it.
Hannah's going to be there.
Yes. But before we do our closing, which I have a warning going off, and this isn't for anything, I've mentioned this practitioner before. He's not an FSM practitioner. He's on Instagram and on YouTube. He's an orthopedic surgeon. He's talking about like-mindedness. His name is Dr. Howard Lux. Lux is spelled Luks. His Instagram handle is HJLux1. So H, letter J, Luks, the number 1. He is a orthopedic surgeon, sports medicine doctor, 20 years of experience. He has a lot of science and evidence-based posts that he does. He will tell arthritic runners to keep running. We need to use our bodies. We can't sit still. He talks about how tendons need load to heal and not boots and casts and immobility. So he's very like-minded as far as how we are looking at the bigger picture of things. And I've referenced some of his work before, so I just wanted to put out there before I forgot again, Dr. Howard Lux. He's amazing. He's very opinionated, but I feel like he's earned it for all the years that he's been in practice. And for me, I really respect doctors who are looking at the bigger picture, and for a surgeon that doesn't want to just inject or cut somebody open, that wants to send them on a walk outside, has a special place in my heart. So that's my shout out to Dr. Lux, and to go to the
hang on, there is data on repairing tendons with eccentric load.
Yes, and that's
there, right up his alley.
Yes. Well, speaking of right up the alley, I have to fly because I have to go on and do crazy things today, but fastest hour of the week is today. So thanks everybody for coming once again. Sign up and go to the Advance. Come see us in Arizona because
it's fun.
It's a week-long party, and we'll see you next week.
We'll see you next week.
All right, everybody. Thanks for coming.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.